I don't have WhatsApp of any messages, anything. I don't know for what I joined also. Here also I'm seeing Central ISAR only one program, but I don't see the speaker. What is the program? Can you just tell me 1 minute?
Yes, ma'am, we are just sharing the program. On behalf of UNS, Dr. Manish would welcome you to this ISAR UNS Fertility Catalyst webinar. This ISAR UNS Fertility Catalyst webinar was incepted with the blessing of Dr. Amit Patki sir and Asha Bakshi ma'am. And today is the 17th in the series of this monthly webinar, which we have been having over the past 2 years. In fact, this was the first webinar we began in 6th August 2024. And in
Manish, I
fact,
received WhatsApp. No problem. I received Faces WhatsApp.
sure, ma'am.
You have on insulin resistant. I understood. Thank you so much. Thank you. We
Thank
can
you, ma'am.
start whenever you wish.
Sure, ma'am. So this webinar began somewhere in 6th August 2024, and this monthly webinar have been happening over the past 17 to 18 months. And we have cherished a lot of memories through these 17 webinars, which we have right from the August 2024. I think we'll relive these memories of these 17 webinar. Just as an intro, I'm Dr. Manish. I'm the head medical and regulatory at Universal Nutriscience. I would request my Vice President and Business Unit Head, Mr. Nikhil Behra, to give a welcome note before we get rolling. Over to you, Mr. Nikhil, sir.
Sure. Dr. Manish, I hope am I audible?
Yes, sir, audible.
Perfect. Thank you so much. So, respected ISAR President Dr. Amit Patki sir, ISAR Secretary Dr. Asha Bakshi ma'am, our national conveners, national and international speakers who are here today, our distinguished chief guest of honor, our chairpersons and esteemed doctor. A very good evening and a very happy new year to each one of you. This, as Dr. Manish has rightly mentioned, it is 17th series webinar, which is in collaboration with ISAR and UNS. On behalf of UNS, I am Nikhil Mehra, Vice President heading Women's and Men's Health Business Unit. It's my absolute pleasure to welcome you all in this highly anticipated Catalyst meeting on the topic updates in fertility management. When I look back, when Dr. Amit Patki was about to take ISAR presidential position, we discussed jointly and on behalf of UNS, we assured Dr. Patki our strong and consistent scientific collaboration, which includes our participation in ISAR conference, also arranging exclusive ISAR UNS masterclass series, and last but not the least, ISAR UNS Fertility Catalyst, which is 17th in row today. And when I reflect, the way ISAR core team was committed, UNS team was equally committed. And hence, all past webinars, I remember that we had every webinar, more than 500 doctors were there. In some webinars, I remember we have more than 1,000 doctors have logged in. And if I, take a unique count, more than 5,000 unique doctors attended this 17th series webinar, from last 17 months. So at UNS, we believe that fertility care is no longer just a clinical need. It's a public health priority, especially in Southeast Asia, where metabolic, lifestyle, nutrition challenges are reshaping infertility outcome. Hence, we are honored to have with us our chief guest, Dr. Sunita Tandulwatkar ma'am, our guest of honor, Dr. Naren Malhotra sir, our national conveners, all of you, your leadership has strengthened not just ISAR, but the entire fertility ecosystem. Tonight's session brings forward two critical pillars of modern fertility management, which includes insulin resistance in Southeast Asians, of course, by our respected speaker, Dr. Nandita Palshetkar ma'am, and WHO Guidelines 2025 by Professor Elan Nashar here. Thank you, ISAR, and thank you, doctors, for your partnership, trust, and engagement over 17 sessions with UNS. While this webinar series conclusive today, our commitment to scientific nutrition-led fertility solution will continue with equal focus and attention. Wishing you all a very powerful academic session ahead. Thank you very much. Over back to you, Dr. Manish Garg.
Yeah, thanks, Nikhilji. So what I'll do is I'll just briefly introduce Dr. Anu Agarwal ma'am and Dr. Fessy Lewis sir. I think Dr. Anu Agarwal ma'am, she's well known along with Dr. Fessy Lewis sir. Dr. Anu Agarwal ma'am is the director of Vanch Fertility and Test Tube Baby Center. She has hold multiple responsibilities in ISAR as well as several research and publications to her credit. In fact, she has written a chapter in a book also. Dr. Fessy sir, he is the professor and HOD at Amrita Institute of Medical Sciences. He has a rich academic career as well as several publications and research to his credit, as well as held different senior positions at different societies. So, with this brief intro, I'll pass it on to Dr. Anu ma'am and Fessy Lewis sir for further proceeding.
Dr. Fessy, please start.
Anu, start.
Okay. So a very warm good evening to all the esteemed doctors present here. And it's a pleasure to welcome you all in this 17th series of ISAR UNS Fertility Catalyst series. We started in August 24. Until now, we have covered various topics related to infertility. And this series, and it's being appreciated by doctors pan-India because of its eagle-eye scientific content and constant guidance of our president, ISAR President Dr. Amit Patki, and Secretary Dr. Asha Bakshi, and obviously whole UNS team. So it's a pleasure to invite ISAR President Dr. Amit Patki for his pearls of wisdom.
Thank you very much. A very good evening to all of you and a very happy 2026. I'm glad and elated that ISAR UNS Catalyst series is in its 17th webinar, and each webinar has had a different angle and much to learn. Today is the big day because we have Dr. Sunita, who's the president elect as chief guest. We have Dr. Narendra Malhotra, past president of ISAR, as guest of honor. And we have two legendary speakers in Dr. Nandita Palshetkar and Dr. Ilan Abutepekar. So I'm so glad and I'm waiting to listen to all of them as all we are on the pearls of wisdom. And the Catalyst series really catalyst our brain into thinking, into learning, and trying to redefine how we practice in infertility. So thank you so much, UNS. Thank you, Mr. Praveen Vite, and the UNS team for having supported ISAR through the 2 years that we have had brilliant webinars, brilliant master classes, and I think we couldn't have asked for more support from UNS. So thank you so much, UNS team, and I wait to listen to the two good speakers. Thank you very much. And also thank you to Dr. Fessy and Dr. Anu, who have consistently chosen good speakers, good topics, and made sure that the webinar happens every month and with a lot of awareness so that lots of more people can join and avail of the speakers. So thank you to both of you.
Thank you, sir. Thank you for the kind words and motivation. And only because of your vision and your insight only, we could start this and continue it with your proper guidance. Thank you, sir. And with this, we go to our Secretary General, Dr. Asha Bakshi. She doesn't need an introduction, but she is the person behind our president and guiding all of us. I think over to you, Dr. Asha Bakshi, for your words of wisdom.
Thank you very much, Fessy and Anu, for inviting me. And I'm so glad that this webinar is doing so well. And always your topics are so informative and so useful to not only just IVF specialists, but to all infertility specialists. So that's really important. And I would like to welcome our president, Dr. Amit Patki, our chief guest, Dr. Sunita Tandulwarkar, our guest of honor, Dr. Narendra Malhotra, and our speakers, Dr. Nandita Palshetkar and Dr. Abul Bakar. And about Dr. Nandita, I'll say that in last 10 days, I've heard her 3 times, and every time the topic is different and really she talks in depth. So I'm looking forward to listen to her this third topic. And it would be nice to listen to WHO guidelines because that is something which has recently come, and it's very important for all of us to be updated with it. And my warm regards to Dr. Geeta Khanna, Dr. Rajul Tyagi, Dr. Sanjay Makwana, Dr. Anuradha Khanna, Dr. Sanjeeva Reddy, and Dr. Seema Pandey. So thank you very much for inviting me, and I'm sure this webinar, I think, one more might be left, so maybe next month you'll have one more, but then it is almost our tenure is about to be over. So thank you so much. Thank you. And my best wishes to Fesi for his future endeavors.
Thank you, madam. And I with this note, I welcome our chief guest for the day, Dr. Sunitha Tandulkarkar, madam. Madam is our president, Foxy president, and is our president-elect. And
Fesi, please, no introduction. Please, I humbly request you.
okay.
You don't need to read all that.
Over to you, madam.
We are all friends. We know each other so well. And first of all, thank you so much for inviting me. It's really great honor and pleasure. And I think so, if I remember correctly, of course, it is your 17th, but I had been to this webinar series once more before, and I equally enjoyed. Thank you, Amit Patki and Asha, for having me today with this. And UNS, you are doing a very good job. I think the team UNS is rocking. They worked with me also, Nikhil. That's wonderful. Today, you have chosen two very good topics and above all, two fantastic speakers. Nandita on insulin resistance in South Asia. I think it's very important that we all understand insulin resistance beyond PCOS, which is so important for whether it is a obesity, whether it is a anti-aging, anything and everything. Insulin resistance is getting explored more, and I'm sure Nandita, it is her topic of a passion on this, and she will highlight all of us very well. And then we have an international speaker. That's another beauty. So your academic program is fantastic. And Professor Ilan sir, who will be talking on a WHO guideline, it will be fantastic. Actually, prevention and management of infertility is such a vast topic, how he will cover and how beautifully we'll come to know as and when we progress. So thank you so much for everything. And I wish Asha and Fesi, both of you, all the best for your future endeavors. Thank you so much.
Thank you,
Thank
madam.
you.
I think next we have our guest of honor. It's none other than Narendra Malhotra sir. I think sir was also was our president and is a guiding and leading light in our specialty. I think if I start reading his introduction, it will take days. So I think let us hear from sir about his words of wisdom.
So very good evening to all of you. It's indeed a pleasure to be here on this UNS Fertility Catalyst, new frontiers and new ideas about fertility. I see a lot of experts and a lot of senior people joined in, and I'm sure that this infertility updates, especially done by ISAR, and the 17th one, which I just heard, are going to be great. And this will be a great collection, which can be later on put and circulated again and again as a video booklet or a video manual for all these. So it's indeed, and the two most important topics being discussed today are what is needed. We all Indians are thin, fat Indians. Even if you're thin, you are fat inside. And that is what our insulin resistance in Southeast Asia, especially in Indians, is the major problem. It's not only PCOS, it's for men also, it's for women also. And there are so many new things coming in for insulin resistance that you don't know what to give. Metformin, of course, even if you're not diabetic, is one of the great things. And there's a lot of talk about myoinositol and dichloroinositol. And we all need to do studies on it so that we can use these to bring down the insulin resistance and make our lives much healthier. The second topic, of course, is prevention of infertility. Now, since WHO defined infertility as a disease,
when it came as a disease, there has to be a prevention. And this prevention is the new buzzword for preventing infertility and the new guidelines. And WHO has come with the guidelines, which includes a lot of things: lifestyle management, diet, exercise, everything, including insulin resistance, and how to prevent yourself from PID, tubal blocks. Everything is there. And these guidelines, again, need to be circulated, revised, and retold to all the juniors and even to us seniors, so that we practice infertility the right way. I thank UNS, I thank ISAR for inviting me here as a guest of honor. And I congratulate all of you for doing this wonderful webinar series. And of course, I wish all the best to Asha Bakshi and to Fessie Lewis and to all those who are also taking part in the executive council election. I know there are many of them. And for that, let's all select the right persons for the right post. All the best to all of you.
Thank you, sir. And I think most of the previous episodes has been uploaded in the ISAR website by the present team. I think few more has to be updated, that uploaded. So as sir told, whoever want to see the previous, we were concentrating initial 15 episodes on one topic: male infertility, endometriosis, minimally invasive surgery, like that. Everything has been uploaded, and few more has to be uploaded, so that, as I told, anybody want to hear from the expert, they can hear from the website. Over to you, Dr. Anu.
Yeah. So we are going to start our scientific session. First is insulin resistance in Southeast Asians by Dr. Nandita Madam. And for this, I'll invite chairpersons, Dr. Geeta Khanna.
Thank you so much.
I was seeing, so from where to start, and it's a beautiful CV, ma'am. Currently, you are National Advisor of IFS UP chapter, and Madam is Founder Secretary of IFS UP chapter, presently member of Executive Committee of IFS, ex-President of Association of Private Gynecologists, Lucknow, ex-Vice President of LOCS, Lucknow, and she has been ex-convener of IFS SIG POR for the year 2018-2019. Various awards and recognition to her credit: Avadh K. Stamb Award, Health Icon, Excellence in ART, Health Icon Award. And she has contributed in many books and she has written many chapters. Welcome, Geeta ma'am.
Thank you so much for the kind introduction, Anu.
Thank you, ma'am. And our next chairperson is Dr. Rajul Tyagi. Yeah.
Thank you, Anu, for making me part of this prestigious webinar. And really, you have chosen a very good topic. And I thanks to Team UNS, Fessie, and Anu for making me part of this webinar. And please don't read the CV. Let's straightforward go to the scientific. You have chosen very good topic, very day-to-day, very good topic.
Thank you. Thank you, madam. And our next chairperson is Dr. Sanjay Makwana.
Thank you. Thank you, Dr. Anu Agarwal and Dr. Fessie Lois for inviting me to this webinar.
Welcome, Sanjay sir. Sir is ex-executive member of National ISAR. Okay. So please, chairpersons, please invite our speaker, Dr. Nandita.
So welcome, Dr. Nandita. And she needs actually no introduction. You know, Foxy and ISAR, the face of Foxy and ISAR is Nandita. So she is an eminent IVF specialist over last 30 years, medical director, Bloom IVF, pioneer in India in so many techniques like ICSI, like laser hatching, blastocyst culture, spindle view, then embryo and ovarian tissue freezing, IMSI, and in vivo vaginal culture, metabolomics, and embryoscope and spindle check technology. Delivered more than 103 orations and more than 1,000 lectures, authored more than 100 chapters and papers, edited 25 books, past President Foxy ISAR, and AIGE and EMOGS, MOGS and MSR, Foxy representative to group members, and Foxy project head PPI and Ampli. Then co-chair REI committee, AOFOG and University Advisory Board PCC.
In one word, I will say only one word for Nandita. She is beauty with brain.
Yeah,
Yeah, one word only for her.
One word description for Nandita.
The beauty with
Beauty with brains. And chosen topic is so good. And as Dr. Narendra has already told, that is a very important topic. And we Indians and Southeast Asians, we are thin fat phenotypes, increased visceral obesities despite normal BMI. And we have insulin resistance at younger age and a lower BMI. And we have genetic susceptibility in early rapid urbanization, and we are epigenetically also more prone to that. So I think you should start your this, and we are waiting for your nice oration.
Thank you. I'm going to just share my screen, but at the onset, I'd like to thank ISAR, Amit and Asha. And Asha, all the best. I think you worked very hard and I'm sure you'll do well and you deserve it. So all the best. And Fessy, all the best for your elections too. And Anu, thank you for inviting me here. I think this one? Yeah. One sec. I'm just... Yeah. How do I use this? Okay. Yeah. I just wanted to... Yeah. Okay. Can you see my screen now?
Yes,
Yes, madam.
Okay, thank you so much. So thank you, Fessy and Anu, for inviting me here. And of course, the UNS team. I worked very closely with Nikhil, Manish and Nakul. And I'm really happy to be here. So, let's get on with the talk. Yeah, you can go. Thank you. So I will get on with the talk. I purposely chose this insulin resistance and metabolic syndrome. As Naren said, it's very, very important. And even Sunita underlined it. So I think what is important we need to understand is that there is a difference in ethnicity. Ethnicity causes differences. And we need to understand that we cannot apply the same, standards as the Caucasians to our Asian women or Indian women. And we need to understand that why the insulin resistance, the metabolic syndrome is more severe in our Asian women than in our, Caucasian counterparts. And that is where our management strategies will differ. And this is where we need to look at it. So as you know, all of us, I'm not going to explain too much of this, but PCOS is no longer just like a reproductive disorder. It's a complex endocrine and a metabolic condition where 20%, I think 1 in 4 patients in Maharashtra, 1 in 3 patients in the north. Even in the south, you see the incidence is really high. So this is what we need to understand, that it is very common in our country. It has not only reproductive dysfunction, but other things like dyslipidemia, dysglycemia, CVD risk, mental health is a big burden in these patients. This is where we need to understand. And remember one thing, that you as a gynecologist are going to see them in their adolescent, in their reproductive age group. And you need to warn them about what will happen in the perimenopause and the menopausal areas. So why, despite so many years of research and so much research, PCOS management even today is still a challenge. We need to understand, are Asians different, and also why the current therapies don't show satisfactory results. So I think we need to really, the underlying thing is answer lies in the ethnicity of PCOS. If you look at the influence of ethnicity on different aspects, if you look at the Caucasians, there is moderate hirsutism, lower DHEAS, SHBG, more obese, more insulin resistance, lower triglycerides, higher HDL, but higher cardiovascular risk, even though that, the thing is which should be the HDL is protective, higher BP. But if you come to our Asian population, there is severe hirsutism, lower SHBG, higher FAI, low BMI, but very high central fat. The fat thin Indian. So your waist ratio is really huge. There's more insulin resistance, there's higher prevalence of AN and acanthosis nigrans. And if you look at the East Asians, that is the Chinese, it's Chinese, Japanese, that part. There's mild hirsutism, higher prevalence of menstrual diseases, lower ovarian volume and follicle count, lower BMI, but higher central fat, increased risk of GTM. So these are the different. Look at the Australians, higher testosterone and lower SHBG in Maori and Pacific Islanders. Maori and Pacific Islanders are more obese, more insulin resistant, and have a worse lipid profile. And let me just get on to Middle Eastern severe hirsutism. We see a lot of patients coming from the Middle East, and they are very severe hirsutism, higher DHES, and more insulin resistance. I think this is the population that we are dealing with. If you just look, I've just put them together, Caucasian versus Asian, and PCOS is higher in the Caucasian compared to the Asian. There is the prevalence of hirsutism is high as 76% as compared to the Asians, exhibit better insulin sensitivity as the Caucasians and have a higher BMI. Whereas if you look at the Asians, 2 to 5% incidence, lower mean hirsutism score, decreased insulin sensitivity, and have a lower BMI, but less muscle mass. And I think that is what makes us very different, very special. And the Asian phenotype, the most common one is phenotype A, where there's hirsutism, irregular periods, insulin resistance, etc. So I think we need to look at our Asian population differently. So why insulin resistance, visceral adiposity, and the metabolic syndrome is more prominent? There is a genetic predisposition, and that is because they have a lower skeletal muscle mass. So the sarcopenia is more evident in these patients. We don't do exercise. We have a sedentary lifestyle. Higher abdominal or visceral fat. The waist circumference is more than 80 centimeters in women, 85 in men. Inadequate physical activity, very sedentary lifestyle, and high consumption of refined carbs and saturated fats. Our diet is full of very rich in carbohydrates, which have a very high glycemic index. And because of this, the exercise, the diet, there is GLP-1 downregulation and UCP1 downregulation. Glucagon-like peptide 1 receptor and uncoupled protein 1 receptor. So what are these two things? And that is what I'm going to talk about in my lecture. So if you look at GLP-1 and its role in PCOS, what does a GLP receptor 1 actually do? It is present all over the body. In the brain, what it does is activates the satiety center, so you're feeling more full. Then the hedonic is, like if you eat something and you get pleasure. So the hedonic center is also down-regulated, so you don't have cravings. So this is what the GLP-1 does. And in the gut, what it does is increases your gas. Yeah? Sorry? In the gut, what it does is increases your gastric emptying time. So the food, you feel full for longer. And it also significantly lowers the fasting insulin levels and improves the markers of insulin resistance, leading to better glucose metabolism and reduced risk of type 2 diabetes. So incretin hormone exhibits the capacity to stimulate insulin secretion in glucose-dependent manner, produced in the small intestine, primarily involved in glucose metabolism. But as I said, GLP-1 agonists have been effective in promoting weight reduction and abdominal fat loss. This is very important, and which can elevate hyperandrogenism and improve the menstrual regularity. So if you look at PCOS patients, the GLP-1 is down-regulated. It does not have the effect what I mentioned before. This particular study shows that GLP-1 levels, both at fasting and in response to a meal, are reduced by 31%. And not only in the fat Asian women, but even in the lean Asian women with PCOS compared to healthy women. And short term oral contraceptives do not alter the GLP-1 secretion in PCOS. And you do see this resistance pattern to what are the hormonal treatments available today. And probably one of the reasons is this GLP-1 receptor. So if you look at downregulation of GLP-1 in lean versus obese, you can see that in the obese, it's even worse. Like in the lean, in the previous study, it showed 30%. Even in obese, it's even lower than the lean patients. So PCOS itself, the pathophysiology is such that the GLP-1 receptors are reduced in these patients. What about visceral adiposity? This is also another very, very important factor. Visceral adiposity, we know that we get a lot of times we get reports of, ultrasound which says fatty liver, grade 1, grade 2, grade 3. This is all visceral adiposity. And the visceral adiposity index, as you can see what I've put it over there, is very, very important. Because if it is high, it is bad. So Asians are, 1 minute, Asians, I need to just move this so that I can, Asians are increasingly recognized as sarcopenic. I said low muscle mass, high fat levels at lower BMI. So even if your BMI is low and you do a DEXA or a body mass assessment, you find the fat levels are more than 25% is normal, 30, 40, 50%, and reduced muscle mass and a tendency for greater visceral over subcutaneous adiposity. So visceral adiposity refers to the accumulation of fat within the abdominal cavity, and it's often described as active fat or the white fat. The VAI is calculated measure that serves as an indicator of the visceral fat distribution and function. And I think this is very important for us to calculate. So as I said, what is UCP1? It is uncoupled protein 1 receptor. The down regulation, what happens is your white adipose tissue does not get converted to brown adipose tissue. The VAT does not get converted to BAT. And that what it results in is increases the visceral adiposity, increases the fat accumulation, and results in hyperandrogenism. So I think the adiposity also predisposes our patients. Why is it not moving? Okay. So what is UCP1 and its role in browning or thermogenesis? If you look at the UCP1 receptor on the white adipocyte, what it does is it stores energy, and energy is required, in the mitochondria. So what it does is it acts on the white adipose tissue, and it converts it into beige or a brittle adipocyte because the UCP1 increases, and there is heat generation. And that heat generation results in browning of the adipocyte and energy expenditure. Now, it is a mitochondrial protein located in the white adipose tissue where it plays a critical role in thermogenesis by uncoupling oxidative phosphorylation, allowing the energy to be dissipated as heat instead of being used to produce ATP. So, and also if the fat accumulation is definitely controlled. So UCP downregulation occurs in PCOS. Because in PCOS, what happens? Because the UCP1 receptor is downregulated, there's decreased thermogenesis, there's decreased energy expenditure, and that results in fat accumulation, and the fat accumulates around the visceral fat. And that is why it is very important. This receptor is very, very important, and we need to know how to modulate this receptor. Now, there is a lot of precision medicine happening. We are doing a lot of genetic evaluation of patients. The UCP1 genetic polymorphism in Asians, if you do a genetic, the gene workup, NGS or the microarray, you will find this UCP1 gene there is polymorphism, and that polymorphism is associated with obesity. And these are the patients where there is a genetic polymorphism. They will benefit maximum from exercise. So I think it's very, very important for us to understand that this allele, the GG type genotype of UCP1, is linked to reduced mRNA expression and increased susceptibility to obesity related issues like BMI is high, type 2 diabetes, and resistance to weight loss. So I think this is something that we must remember. So UCP1 gene polymorphism actually contributes to the Asian PCO phenotype. This is linked to, obviously, as I said before, increased BMI, but in moderately obese population is where you see this polymorphism. So even in young Asian females, in the Asian population, you get insulin resistance at an early age, you get metabolic syndrome at an early age. And these are probably some of the reasons why we are genetically predisposed to it. So why do Asian populations struggle to lose weight despite multiple intervention? This UCP1 polymorphism linked to that reduced mRNA, especially in the Asian population, does result in kind of a resistance to the normal treatment modalities that are present. So that is why in a lot of patients, metformin and oral contraceptive pills do not show satisfactory results. So PCOS management, what is it? And I think new data is emerging, new concepts are coming in, and that is what we are going to discuss. So lean and obese, both patients show a 31% reduction in GLP-1 expression. So there's what does that do? Increases the insulin resistance, causes hyperandrogenism, increases the LH-FSH ratio, increases anovulatory cycles. And remember, your treatment with metformin or OCPs does not impact this GLP-1 expression. And that is why there are enough studies which show that GLP-1 level is unchanged during the treatment. And if you have metformin plus OCP, you can result in increased risk of hypoglycemia, and that could be associated with increased insulin secretion. Remember one thing with GLP-1, what happens is even if your sugars are high, then only it brings it down. There's no reason for hypoglycemia. So it acts on the insulin secretion only when the sugars are high. So that is another advantage of GLP-1 receptors. Ever wonder why metformin and OCPs do not show? Because the Indian phenotype, obese and lean, have a very high visceral adiposity index. So because of the PCOS, there's increase in visceral adiposity, increases in fat accumulation and hyperandrogenism. And therefore, metformin doesn't affect. So how are we going to help these patients? Yes, evidence-based international guidelines on 2023 lifestyle modification is the first line of therapy. 150 to 300 minutes per week of moderate workout, or a 70 to 150 minutes per week of high-intensity workout does help. And of course, the diet, high fiber, lean protein, low carbohydrates, and a low glycemic index diet is important. Have you ever wondered how it acts? And that is what I'm going to show you. In PCOS patients, let's look at the exercise part of it. If you exercise as required, it increases the BIBA, and that causes increase in the uncoupling protein 1. And that converts the white adipose tissue to brown adipose tissue, and the visceral adiposity decreases, the fat accumulation decreases. So therefore, exercising does help. The other part, if you look at the diet, high fiber, low protein, lean proteins, low carbohydrates, low glycemic index diet on the body, it increases your GLP-1 expression, That reduces your insulin resistance, reduces the LH-FSH ratio, reduces the GnRH pulsatility, reduces your hyperandrogenism, and it increases your SHBG. So in short, you're treating the pathophysiology by doing this. But of course, everybody cannot stick to it. So remember one thing, lifestyle modification is important, but there is something else that also we can do. PCOS women should aim to lose 5 to 10% of their body weight in the first year after diagnosis for improved clinical outcomes, reduce body weight, and of course, better cardiometabolic health if you do 150 minutes of weekly exercises, the sarcopenia, the viscera, the adiposity, central adiposity definitely reduces. So definitely there are methods in which you can help, and what is it? So look at the diet part of it. 25 to 30% should be your fat, which is 40 to 50 grams per day. So how do you do it? Increase your omega-3 fatty acids, salmon, mackerel, tuna, nuts, seeds, flax seeds. Decrease the omega-6 fats, that is your animal fats and processed foods. Optimal ratio of omega-6 to omega-3 is 4:1. Include monosaturated fatty acids like vegetable oils, nuts, seeds, and avocado. Come to the carbohydrate. It should be 40%, not more than 150 grams per day. Low glycemic index food like bran, cereals, sweet potatoes, milk, oatmeal, fresh whole fruits, non-starchy vegetables like beans, leafy greens, broccoli, minimal starchy vegetables like potatoes, corn, and peas. Let's go to the lean protein with low fat content. That's chicken, meat, fish, yogurt. Meat could be turkey, and it should be like 100 to 110 grams per day. And fiber. I think fiber is very, very important. 25 to 30 grams per day. It's a lot of fiber. Good sources yield only 3 grams per serving. So whole wheat, rye, oats. I think fiber intake is something which really helps us. Now, if you take this, if you do all this, you definitely improve. But a lot of times, people cannot follow this and they need help. So today, there are different things that are available. So I'm going to discuss this in my last slide only. So first, we need to understand the ethnic variation in our patients and the manifestations of PCOS and what it actually reflects. Phenotype A dominates in the Asian women with PCOS demanding very targeted attention. The GLP-1 and the UCP1 downregulation drive severe insulin resistance and visceral fat accumulation. The current therapies of metformin, OCPs, or their combination fail to address this root cause. So yes, we do have oral GLP-1 agonist, receptor agonists, which are available today. We have liraglutide, we have semaglutide, we have tirzepatide, and there is a fourth one which is in the pipeline, and a UCP1 activator also, EQ, OQ, I think, therapies. These are game changers for effectively managing Asian PCOS phenotypes. So those patients who are struggling, who have not benefited with diet and exercise, I think this is something you can add to the armamentarium to help them become healthy. So yes, even if the patient is a thin fat Indian, you can use semaglutide because it really reduces your waist circumference by more than 20 centimeters in 1/3 of the patients. And especially these patients who are insulin resistant would definitely benefit from them. Then the EQ also. This tablet has M&M and UCP regulator. Now, this proteins, they help in improving the visceral fat. I think all this combination will help us to treat our patients who are resistant, and we should look at that. Thank you very much. I hope I didn't finish too early.
Thank you, Dr. Nanita ma'am. It was excellent topic, especially, and you have covered in such a nice way that you have explained very nicely about the Asian phenotype, about the genetic predisposition, and the more or less you have given such good tips to handle these situations, which is really excellent. I hope everybody must have enjoyed, must have taken a lot of take-home messages from it.
She has touched the latest also. Everything was
Yes.
nearly complete. Everything complete.
Thank you, Geeta. Thank you, Geeta. And thank you, Rajul. You're muted, Rajul. But I think, it's something that we should be aware of. And when we are treating our patients, it's something that we can look into. And I think and there are a lot of now companies, I don't know, is the UNS getting semaglutide or no?
Dr. Nandita,
These are getting-
when we have to start a GLP-1 oral antagonist,
Yeah.
do we have to postpone the pregnancy plans?
Okay, yeah, that's a good idea. I think we can talk practically about how we can use this drug. You cannot conceive with ULP, GC, what is a GLP-1
GLP.
agonist?
Oh,
Because it has not been tested in pregnant women, and they have not done any tests. So the half-life is 1 week. So it takes about 6 weeks to 12 weeks to actually disappear. But by 8th week, it is 1% in the blood. So it's definitely safe. And in high doses, they have found no effects. And there are now a few studies because people have got inadvertently pregnant while on semaglutide. And there are studies showing that there is no problem with them. But these are, of course, few in numbers and we're waiting for more. So what I would advise is you start with the smaller dose, 2.5 or 0.25, 0.25 of semaglutide, and you give it for 1 week, 1 month, and then step it up gradually, because otherwise the side effects are too bad. The nausea,
okay.
constipation, diarrhea is a lot. So you need this patient to adjust to it. And a lot of my patients are very well settled with 5 milligram dose or with 2.5. You don't need to increase the dose, because what you need is the craving, the satiety reduced. And remember one thing, this is a treatment which has to be combined with exercise and diet. You cannot do it by itself. And because if you do it just by itself, you will end up with a lean muscle mass loss. And though there is a new study which is known as Semaline, which was just published in 2025 August, which actually says that the fat loss is more than the lean muscle mass. And it's better. And the tirzepatide doesn't show any muscle loss at all.
This is another question, Dr. Nandita.
Yeah.
When we have to stop the drug, like suppose we have to give the 8 weeks after the drug, and then we have to plan the pregnancy.
Yeah.
Can one get the weight again?
Okay, that's a very good question. So, what does it act on? GLP-1, satiety, hunger, craving. You take it off, it's going to come back again. So that's why the lifestyle modification is very important for the patient. But like my experience has been that, if the woman has lost 10 kilos, she's motivated in keeping it back.
Yeah.
Most of the patients, may gain 25% of the weight if you're not careful. But if you're careful, you can keep the weight off.
That's great.
Because as it is, the stomach shrinks, you've been eating less, your calorie intake, you learn to eat smart, nutritionally dense, calorie deficient food. And that's how you have to do it. And a lot of supplementation is required. I would give supplements to all my patients. I think, the coenzyme Q10 is very important, especially if you're taking statins. And magnesium, zinc. Rohan is giving me inputs, magnesium and zinc. I think all the multivitamins, all that is very, very important because your nutrition becomes very low. So there may be a deficiency in that.
I think
Madam,
the
can I
good
add one
factor is
point?
very good. Feel good is going to check everything.
Biotin for hair, because a lot of people complain of hair loss.
Yes.
Madam, can I add one point? One
Yeah.
of my friend and endocrinologist in Middle East has been using for 3 years. He told that rather than increasing, as Madam told, continuous low dose prolong, so that people will change the lifestyle modification, that has been more effective than increasing the dose and some side effects, some problems coming.
So Fessy, I'm using it for 3 years personally. 15 milligrams I'm using. I've reached 2.4. Now,
That's really good.
everything I'm feeling, I've plateaued. I've lost my 30% weight. So I have to be very careful. I'm very particular about my diet, but my sweet, so if I don't eat throughout the day, I don't feel hungry. Raat ko bhook lagti hai. So you have to adapt and you have to change and you have to be a lifestyle. It's not easy otherwise.
Good tips.
Yeah. And genuinely, the way it's bad mouth on social media, it's not that bad.
It's not there. Yes.
It's a very good treatment protocol which is available to us Indians, especially because of our visceral fat. Okay, because if you look at the women after pregnancy, they put on abdominal weight. So I think that is what is really important, and you have to be careful because you can't, we are all 50 plus. Let me put it very nicely. We are all 50 plus, and we need to look young. So we can't lose too much weight where our face becomes marasmic. Yeah, Asha is laughing. Yeah, Raja. I think
Yes. Your lecture was really mind blowing. And after listening your talk, I will also start giving to my patients. Up till now, I didn't start. I didn't give anyone.
A patient comes to your clinic and she says she's a little plump, and you put her on, you tell her, I'm going to make you lose weight. She's not going to run away to your neighboring IVF center, Rajul. So first, prepare her embryos, freeze them, and then she's motivated because the embryos are ready.
That is a better way, yes.
Wait before the frozen thaw ET. So I think that's the way. The only place where I start pre-pickup generally is when I have very bad quality oocytes because of the obesity itself. So then, yeah, helping getting the weight down may help a few patients get better quality eggs.
That's really good. Good, nice trip, ma'am. Thank you.
Thank you. I know I want to listen to the next speaker, but I don't think, what time was his talk?
No, after yes, madam.
Acha, he is already online. Then
yes.
I was just chatting because I didn't see him. Nurse.
Okay. Dr. Abu Bakr has joined. Sarah has joined.
Yes.
Yes.
Thank you, chairpersons. Thank you very much.
Thank you,
Thank you
chairperson.
very much.
Over to Dr. Anu for the next session. Anu is there?
Yes, I am ready.
Hi, Dr. Abu Bakr.
Yes, hi. Thanks a lot for invitation.
No, we are starting
from Egypt to Indian. I would like to thank ISAR. I would like to thank all of my friends, Dr. Amit, Dr. Asha, and Dr. my good friend, Dr. Redi, Dr. Khana, Dr. Bandi, and I am ready to address the latest guideline of the WHO.
We'll start with the chairperson, sir.
Bakr, please wait. They have to introduce you and they have to call the chairpersons. Just a minute. Wait.
Yes. Thank you.
Go ahead.
Yes, so our next session is on WHO guidelines for prevention of management of infertility. So we have the chairpersons. First, we have Dr. Anuradha Khanna. Madam, as you all know, can you show the madam's CV? Okay. Madam was the president of UP chapter of GYN and ex-head of Department of Obstetrics and Gynecology, BHU Varanasi, founder president of Society for Fetal Medicine UP, ex-president of Varanasi Obstetrician Society, founder president of Varanasi Menopausal Society, and she was organizing secretary for a number of conferences and won number of awards, including Fellow of Academy of Medical Science Award in 2016. Our next chairperson is Sanjeev Reddy sir. Sir was my undergraduate examiner way back, and sir is a senior consultant in reproductive medicine surgery in Royal Hospital Fertility Center, Chennai. Sir started the first MCH, started as DM course in India in SRMC as professor and HOD. Later we followed the suit, and now there are 9 colleges, and also former HOD of the SRMC, and former awarded several awards, including Dr. B.C. Roy National Award and Distinguished Faculty Award. That was one of the few rare awards among the several awards he got, and he has contributed academically in several ways. and motivator and guide to most of us in this part of India. We welcome you, sir. Our next chairperson is Dr. Seema Pandey. She is a fellowship in minimal invasive surgery, and presently he is our honorary librarian of ISAR, and also fellowship in reproductive medicine and fellowship in regenerative medicine and stem cells, diploma in ultrasound with several awards to her. We welcome Dr. Seema, and over to chairperson to introduce our distinguished international speaker, Professor Abu Bakr Muhammad Al Nashar.
Thank you, Fessi.
Can you introduce the speaker, Dr. Seema?
Yes, I can. I thought that, yeah, welcome, Professor Abu Nashar. He is Professor Ops Gynae, Bena University Hospital, Egypt, President of the Clinical Society of Ops and Gynae, President of the Egyptian Committee of Upgrading Obstetrics and Gynecology Professors, member of the Egyptian Board of Fertility Sterility Society, and member of National Committee of Obstetrics and Gynecology. Hello, can you hear me?
Yes. Voice was breaking, that's all. It was okay.
My voice is breaking. I'm an OT actually.
Chairpersons, please call the speaker because your Seema's voice is breaking.
Sir, Ella, sir.
Yes. Hello,
Ella, sir,
my dear friend. How are you? Nice to see you and to listen to you. Long time ago. Yes.
Like you can share your slides and start your lecture.
I can share the slide.
Yes, sir. The screen is visible, but please make it slideshow, sir.
Yes, clear now?
Yes, sir.
So, again, I would like to thank the ISAR for inviting me for this prestigious meeting, and I will address the latest guideline of the WHO for prevention and the management of infertility. What is the objective of this guideline? To provide an evidence-based recommendation, and the most important, and this is the subject of our society, is to provide a source to adopt, adapt, or update their national guidelines. So we can take this guideline and adapt it according to our circumstances in India or in Egypt. It is an evidence-based guideline, and the strength of evidence according to the grade. There is a strong recommendation and there is conditional recommendation according to this guideline. I classified the contents of these guidelines into, number one, general principles. What are the general principles for management of infertility? Then, how to prevent. And we will address the male factor, ovulatory factor, tubal factor, uterine factor, and unexplained infertility. We will see how to assess and how to treat, and then we can summarize in algorithm, and at the end to have a conclusion. Let us start by the general principles, and all of these are good practice statement, and this will address the evaluation of infertile. That's to say, as you know, any evaluation, we should start by the history, and we should listen to individuals and the couples and respect their preference and discuss if psychological and social demand is needed or not. And we should provide referral of the patient if there is any psychological or social need. The second in the evaluation is the examination, and this examination should to ensure that the evaluation is systematic and cost effective. Every step should be cost effective. And the third in the evaluation is the investigation. And investigation should be based on the clinical finding from the medical history and from examination. The treatment. We should take the decision of the treatment depending on what are the benefits and what are the harms of this line of treatment. And what is the patient value? And again, the preference of the patient. If this line of treatment is visible, what is the cost? And what are the resources available? And we should consider the cost effectiveness. As I mentioned, every step in evaluation in the treatment should be cost effective. What is meant by cost effectiveness? We should select the least expensive but effective. This should be provided initially. And not only to give the treatment, we should follow up our patient and to see if there is any potential risk and to address this risk if it is present. Lastly, documentation of the outcome. So these are the 5 principles for treatment of infertility. Let us start by prevention. And as we know, prevention is better than cure. And the prevention, according to the WHO guideline, can be summarized in 3 words. Number 1, to provide information. Number 2, sexually transmitted disease to address. And the number 3, to address the tobacco smoking. For the best of my knowledge, and I have a lecture about this prevention of infertility in the male and the prevention of infertility in the female, we have many recommendation or many lines for prevention. But according to the WHO, they concentrated, they focused on these 3. Number 1, the information provision on fertility and infertility. And this should be for the general population of reproductive age. And again, we should use the cost strategies or whenever there is an opportunity. Just to say, in the schools, in the primary health care centers, in the reproductive health clinics, and we should tell them how to reduce the risk factors for infertility, to tell them about the lifestyle modification to increase the fertility, and to tell them about the relation between age and decline in fertility. This is for the general population. And information for the couples with infertility, it should be low-cost lifestyle advice before and during infertility treatment. And we should tell them how to get the balanced diet, the appropriate diet, to stop alcohol, to stop smoking, to have physical activity, and to get the appropriate weight by weight management. The second line for prevention of infertility is risk reduction from sexually transmitted infection. And the couples should be routinely informed about the relation between sexually transmitted infection and infertility. And if the infection is not treated, it will lead to infertility. Couples should be encouraged to seek medical advice and prompt treatment if there is symptoms of sexually transmitted infection. And we have the WHO guidelines for management of sexually transmitted infection. The third is risk reduction from tobacco smoking. And this is, we should have a brief advice to all the tobacco users, and this assessment of the patient is smoking or not is an integral part of the history of taking the lifestyle. And we should tell them the association between infertility and smoking. Even the previous smoking has an effect on the fertility. And we should tell them about the risk of infertility and how it is higher among women than among the men. So this is regarding the prevention, and again, we can summarize it in 3 words: information, reduction of tobacco smoking, and risk reduction of sexually transmitted infection. Let us go to the before going to this, the WHO has a system or a protocol for the management of smoking. And this can be summarized into 5 A's. Number 1, ask about tobacco use. Number 2, advising to make quit attempt. Number 3, assessing readiness to quit. And number 4, assisting in making a quit plan. And lastly, the 5th A is arranging a follow-up. This is the protocol of the WHO for stop the smoking for any person. And also, according to the WHO, there is a range of intervention to assist in cessation of the tobacco. And this is the guidelines are available in the WHO. Let us go to the factors, and we'll start by the male factor. And as I mentioned, we will address 3 points. Number 1, how to assess. Number 2, how to treat, and then to have an algorithm. For the male factor infertility, to assess semen analysis is the cornerstone for the assessment of the male. And if we have 1 or more semen parameters outside the WHO reference, if we have any abnormality in any item, we should repeat the semen analysis after a minimum of 11 weeks. But if all the semen parameters are normal, there is no need to repeat the semen analysis. And we should follow the cutoff levels of the latest WHO laboratory manual in 2021. Just to remind you, this is the latest one, WHO, where the sperm concentration 16 million per mil, the total motility is 42%, and the normal morphology the same. There is no change between the 2010 and the 2021. And this is algorithm for the male factor infertility. And as we see here, the basic semen analysis. And then if there is abnormality, to repeat after, as I mentioned, after 11 weeks. And according to the result, we will take the treatment. But if all are normal, there is no need to treat, and we should do the investigation and to diagnose if there is a male factor infertility and the other female factor infertility. What's the treatment? First, we will address the antioxidant, and this is new. And there is a controversy between the different guidelines. According to the latest WHO guideline, if one, regarding the use of antioxidant, if 1 or more semen parameters that are out the WHO reference range, WHO didn't make a recommendation for or against the antioxidant. They are not against or they are not with the use of antioxidant for management of abnormality in the semen. Why? Because according to this guideline, the effect of the antioxidant is currently not known. For the other guidelines, they are against the antioxidant, and they mentioned there is no increase in the live birth rate with the use of antioxidant. Maybe there is improvement in the parameters, but our objective at the end is the live birth rate. For treatment of varicocele, it is very important to know what are the indications for treatment of varicocele by varicocelectomy. Number one, we should have male infertility. Number two, we should have a palpable or a clinical varicocele. And we should have abnormal semen parameters. And this male is not going to do ART. So we should have 4 criteria before advising the patient to do varicocelectomy, and this varicocelectomy either surgical or radiological. But the surgical or the radiological treatment is recommended over the expectant management. And to consider surgical or radiological, we should assess the visibility, the availability of the trained health providers and the patient preference. To do microscopic or non-microscopic varicocelectomy, microscopic surgery is recommended over the non-microscopic. And we have microscopic and the non-microscopic. And the non-microscopic may be open approach or laparoscopic approach. And according to the WHO guidelines, using either inguinal or retroperitoneal surgical procedure can be adopted. And to select the inguinal approach or the retroperitoneal approach, we should consider again visibility and the availability of the trained healthcare provider. So this is regarding the male factor, and we are sticking to the WHO guideline. The second factor is the ovulatory factor, the ovulatory dysfunction. How to assess? If we have regular menstrual cycle and the normal physical examination, in this condition, to assess ovulation, they are recommending the mid-luteal serum progesterone rather than performing folliculometry. And if indicates no ovulation, if there is no ovulation, according to the mid-luteal progesterone, repeat measurement is indicated to decrease the risk of inaccurate diagnosis of anovulation. And as we know, the mid-luteal serum progesterone are assessed 7 days before the expected onset of the next menses. If there is a suspicion of anovulation, or if there is oligo-ovulation, we should assess the reproductive hormones related to the hypothalamic pituitary ovarian axis. That's to say, to ask for FSH and LH. And in this condition, it is recommended to be the basal FSH and the basal LH. That's to say, to be done in the second day or the third day of the cycle. In some clinical presentation, E2 and testosterone is indicated. So we will select the hormonal assay according to the clinical situation. And TSH and the prolactin may be indicated based on the clinical presentation. Just to remind you about the ASRAM is recommending the TSH for all the pregnant ladies. And only prolactin is recommended if there is ovulatory dysfunction, or if there is galactorrhea, or if there is suspicion of pituitary adenoma. But according to the WHO, TSH is not routinely indicated, but it is indicated only if there is a clinical suspicion of in the history or in the examination. And again, the choice of the test should be based on the clinical finding and the history and the physical examination, as we mentioned. If other causes of anovulation and oligo-ovulation have been excluded, the diagnosis of low ovarian reserve should be based on the age rather than the diagnostic test. So we excluded the causes of anovulation or oligo-ovulation, and in this condition, we should assess the ovarian reserve. And according to the WHO guidelines, the age is the most important. Just to remind you, the age will reflect the quality of oocyte, while the antral follicle count and the AMH will reflect the quantity of the oocyte. The ovarian reserve test recommended by the WHO, antral follicle count, AMH, or even the basal FSH. Just to go to the recent ISRI guideline, they didn't mention the basal FSH and they recommended only the antral follicle count and or the AMH. The selection should be based again on acceptability and availability and according to the resources. And this may why they are still recommending the basal FSH, because the basal FSH is cheaper than the AMH, and the antral follicle count may be not available if we have no ultrasound machine. Regarding the age, according to the guideline, it is the most important predictor of ovarian reserve. But I mentioned the age will reflect the quality of oocyte. And also regarding the age, we cannot depend on the age. The age to predict the ovarian reserve may be limited. Maybe the patient is suffering from premature ovarian insufficiency, and still she is young, but the ovarian reserve is very low. So again, we should depend on the age, and we should depend also on the antral follicle count and the AMH. What's the treatment of the ovulatory dysfunction? The most common cause is the polycystic ovary syndrome, and letrozole is recommended over clomiphene citrate or metformin. And it is recommended to use letrozole alone. There is no need to add metformin rather than metformin. But in some countries where the off-label use of letrozole is not permitted, use of metformin rather than clomiphene citrate alone or metformin alone. And it should be the first line of treatment of polycystic ovary syndrome, which is lifestyle intervention. Healthy diet, regular physical exercise, and weight management to reduce weight. If after use of letrozole or clomiphene citrate with metformin, the indication or the recommendation to use ISAR gonadotropin, not laparoscopic ovarian drilling. And this is in agreement with all the recommendation. Now, the laparoscopic ovarian, the role of laparoscopic ovarian drilling is declining. And according to the ISRI, the recommended is gonadotropin. And the alternative is laparoscopic ovarian drilling if we have another indication for laparoscopy, or if we cannot follow up the patient with use of gonadotropin. If there is unsuccessful letrozole, unsuccessful clomiphene citrate with metformin, unsuccessful gonadotropin, and in this condition, IVF. So IVF is not a first line of treatment, is not a second line of treatment, but a third line of treatment of polycystic ovary syndrome. If there is hyperprolactinemia, cabergoline is recommended over bromocriptine. And this is algorithm for management of polycystic ovary syndrome. As we see, there is the first line medication, which is letrozole. The second line is gonadotropin. And third line is IVF. The third is the tubal disease. How to assess the tubal disease? We can use the hysterosalpingography or the HICOSI, the hysterosalpingo contrast sonography. And when selecting the HICOSI or hysterosalpingography, we should consider visibility, we should consider availability, and we should consider also if there is an allergy to the dye used in the hysterosalpingography. The guideline recommended for assessment of the tubal disease is to use Hull and Rutherford classification. And they mentioned that this classification is simple and applicable and also predictive. It can predict the live birth rate and the ectopic pregnancy after surgery. And this is this classification. As we see, we have mild or grade 1, where tubal fibrosis absent, mucosal appearance is favorable, and in this condition, the pregnancy rate is 84%, and the ectopic pregnancy is only 7%. The intermediate or the moderate or the grade 2, when we have unilateral severe tubal damage, limited dense adhesion, and the pregnancy rate in 72%, and the ectopic pregnancy is higher, 23%. And the severe or grade 3, where we have bilateral tubal damage, tubal fibrosis, and in this condition, the pregnancy rate is only 28%, and the ectopic pregnancy is very high, 57%. So the treatment is dependent according to the age and according to the degree of the tubal disease. If the age is less than 35, and the classification is grade 1 and 2, surgery rather than IVF. So still, there is a role of surgery for treatment of tubal disease. And after surgery, we will give a chance for the patient for 1 year. And if there is no pregnancy, IVF is indicated. And this recommendation doesn't apply for females who had a previous tubal sterilization. If the age is less than 35, but there is a severe tubal disease, that's to say the classification is grade 3, in this condition, IVF rather than surgery. And the recommendation again doesn't apply to females having a previous tubal sterilization. But above the age of 35, whatever the tubal disease, there is no need to assess the tubal disease in this condition, IVF rather than surgery. Of course, if there is a hydrosalpinx, and we will address this in the next slides, we should treat it before doing IVF. And for the hydrosalpinx, we can do either salpingectomy or tubal occlusion before IVF. And again, because it is repeated in every step or every line of treatment, we should consider visibility, availability of the trained doctor. Either salpingectomy or tubal occlusion rather than transvaginal aspiration. Transvaginal aspiration is not recommended as a first-line treatment of hydrosalpinx. And but where salpingectomy and the tubal occlusion are not available or visible, in this condition, transvaginal aspiration may be offered. For the uterine factor, how to assess the saline infusion sonography, SIS, rather than 3D ultrasonography. And where the 3D ultrasonography is already available in this condition, 3D ultrasonography may be the preferred option. 3D ultrasonography rather than 2D ultrasonography, where the resources are available. SIS rather than 2D ultrasonography. So according to the guidelines, the saline infusion sonography is recommended as a first line or as a first method for assessment of the uterine cavity. SIS rather than hysterosalpingography. The SIS is has an accuracy. The accuracy is more than that of hysterosalpingography. Again, what we will do if the resources are unlimited, we can use either the 2D ultrasound or the hysterosalpingography. And we should follow up the patient if we have a negative finding on the 2D ultrasonography, but still we are suspecting uterine cavity disorder because the 2D ultrasonography is not accurate in assessment of the pathology, the intrauterine pathology. So if we depend on it, it is insufficient and it is inaccurate, and the recommended is the SIS. And this is algorithm for assessment of the uterine cavity. And as we see here, the recommended is SIS. And when there is a positive result, uterine cavity disorder, it should be treated. And when it is negative, normal cavity. And this is the recommended. The other, if the no resources, we can depend on this redo the ultrasound and so on. What's the treatment? For females with infertility and uterine septum who have no history of recurrent pregnancy loss, hysteroscopic septum resection not performed. So according to the guideline, if we have a septum and there is no recurrent pregnancy loss, it is a primary infertility, there is no indication to do septoplasty. The last is unexplained infertility. How to diagnose? According to the guideline, we should have all of the following should be present to diagnose unexplained infertility. Number one, to achieve a pregnancy after 1 year of regular unprotected sexual intercourse. Number two, normal physical examination and the medical history in both the male and female. Number three, confirmation of ovulation and the patent tubes in the female partner. Number four, semen parameters that are within the WHO reference range. So we should have all of these three criteria to diagnose the unexplained infertility. Just to remind you, the last ISRI guideline for definition of unexplained infertility, they included number one, age. It should be less than 37 years, and included also the frequency and the timing of sexual intercourse. It should be every 2 to 3 days during the fertile period. And this is algorithm for assessment of or for diagnosis of unexplained infertility. We will do as we should fulfill the 4 criteria for diagnosis of unexplained infertility, to take history and physical examination, and to assess the male by the semen analysis, and so on. So what's the treatment of unexplained infertility? We have first line treatment, second line treatment, and third line treatment. The first line treatment of unexplained infertility is expectant management rather than unstimulated IUI, and expectant management rather than ovarian stimulation with timed intercourse. So the first line of treatment is expectant management, and this indicated if the duration of infertility is short and the age of the patient is young. And expectant management, what's meant by expectant management? No medical intervention, advice on lifestyle, and advice about the most fertile days of the menstrual cycle. We mentioned the fertile window, which is 1 to 6 days before ovulation. The start of the fertile window is not known. It is variable from one patient to another, but the end is well known. The end of the fertile window is the occurrence of ovulation. And in the expectant management, we should monitor if pregnancy will occur or not. According to the ISRI guideline, we have a prognostic models, and we can detect if it is more than 30 or less than 30. And according if it is more than 30, we can do expectant management, and if less than 30 in 1 year, in this condition, active management in the form of stimulated IUI or IVF. The duration of the expectant management is ranging from 3 to 6 months, depending on the duration of infertility and the age of the patient. The second line management of unexplained infertility is when the expectant management is unsuccessful, is stimulated IUI, not clomiphene citrate or letrozole. It should be stimulated IUI. And in this condition, we can stimulate with clomiphene citrate or letrozole. And in this condition, it's called not stimulation, it's called over stimulation, sober stimulation. The patient is ovulating, but we want to increase the number of oocytes to increase the probability of pregnancy by giving clomiphene citrate or letrozole. And there is no difference between letrozole and clomiphene citrate in unexplained infertility. But as we know, in polycystic ovary syndrome, the letrozole is recommended over clomiphene citrate. The optimal number of stimulated IUI ranging from 1 to 6. But the patient will not wait to have 6 trials. Mostly, after 3 trials, she will please to have another line of treatment. The third line of management where the stimulated IUI has been unsuccessful is IVF rather than ICSI. Because it was found that there is no difference between the outcome of IVF and the ICSI in management of unexplained infertility. And this is algorithm for the management of unexplained infertility. First line treatment is expectant management. Second line stimulated IUI. And third line IVF without ICSI. To come to the conclusion, for infertility, prevention is better than cure. And we should prevent infertility by providing, as you mentioned, information, risk reduction of sexually transmitted infection, risk reduction of tobacco smoking. And we should diagnose and to see the cause of infertility. Is it male factor, ovulatory factor, tubal factor, uterine factor? And at the end, we should treat of the infertility and to assess and provide or refer for psychological support if needed. Thank you. Shukran. Yes?
May I come in?
Yes, sure.
It's so nice, Professor Abu Bakr, that it is just like a UG/PG class for
Yes.
all of us. And
Yes,
I
sure.
really appreciated it a lot, because nowadays I see the initial history taking, clinical examination, the workup, the environment is not well taken by the doctors practicing and also in the hospitals, institutes. So this is the
Yes.
most important thing you have mentioned, all regarding from the history, the STI, the examination, and the adequate test, not too many tests to be done, and evaluation of the whole body with the couple, and understanding both male and female infertility, and understanding their surrounding when she will like to become pregnant. As you mentioned, in the education, the
Yes.
education in the schools, they are the most important thing, because they all are becoming girls and boys career oriented. So they should
Yes.
understand their reproductive life also. And chances of STI, RTI, they are having it. So it's a very informative talk, I will say. I liked it very much. And you have stepwise step given from the basic to the recent evaluation. And very nicely you have told us about the factors, the uterine factors, the tubal factors, and to how to evaluate, not just jumping for investigation from here to there. I really enjoyed your talk, and the treatment also you have given so precisely, when to become expectant and when to go for intervention, how long should you wait, how many cycles should you wait, and what the drug should be used for stimulation. I'm very much liked your topic, because it is very basic to the update,
And I must congratulate to you and also to the team, Anu and Dr. Fezzi Lewis and everyone who has prepared this program. And I'm thankful to them to making me chairperson of this. Thank you
Thank
so
you
much.
for this. Thank you very much. I am appreciating your comments.
Thank you, Dr. Elsonar, for simple way you summarized all the guidelines. It is very useful for, it's very basic, but it will be useful for the practicing gynecologist. Just I will have some queries or I want your opinion. So they mentioned in the varicose vein, if it is there, either surgery or radiological thing. So what is your opinion? What you will advise? Advise surgery or radiological? Are you doing the embolization, varicose vein, or the surgery?
They are not done in our country. Or all surgery.
Okay. Next is the
no, I want to ask you, is it done in India?
No, usually we will prefer surgery. We won't advise for radiological embolization, usually. That's not rarely
like
done.
Egypt. Like Egypt.
Okay. Next is tubal evaluation. Whether you're going for the HSE or you are doing routinely HICOSI there.
HICOSI is not available in Egypt, and the dye is expensive and not available. We are
Then why
depending
this
on
WHO, they, when other things are, they're telling, they're advising HICOSI like.
No, but this is according to the guideline, and we should stick to the guideline. But we are using the histopathology or the SIS.
One more thing, they have not mentioned anything about the commented about the laparoscopy.
Again, sorry?
Laparoscopic
Laparoscopic procedure, tubal evaluation.
They didn't mention anything about the laparoscopy, but the laparoscopy is not a routine for assessment of the infertility, and we have indication if we have any abnormality in the ultrasonography or hysterosalpingography, or if we have a suspicion of from the history of examination of pelvic pathology like pelvic inflammatory disease, history of ectopic pregnancy, or any previous operation in the pelvis. In this condition, laparoscopy is indicated.
But they should have mentioned, no, like if it is not.
And also, if allow me. Sorry?
No. They are telling like that 3 to 6 cycles you do the IUI. If it is not successful, go for IVF. Here also they should mention, no, like at least they should have mentioned the role of laparoscopy in cases
I
where
quite agree with you. You see, we can criticize also. The guideline didn't mention anything about endometriosis.
One thing I would like to say, the Hull and Rutherford classification you have mentioned is laparoscopic, I think.
Yes, laparoscopic.
That is laparoscopic.
Yes.
Because the stage 1, 2, 3 you have mentioned.
Yes, laparoscopic.
And how much involvement is there? That is.
And you see, there is another classification. There is the British Fertility Society classification of the tubal disease, and this is dependent also on the laparoscopy. But clinically or practically speaking, if we have a hydrosalpinx with a diameter 1.5, it is moderate to severe disease.
And another thing is for ovulation confirmation, they are telling like that to do the serum progesterone.
Yes, you mentioned like that. And in Egypt, we are not depending on this. And as I mentioned at the beginning, my dear friend, they mentioned that we should adopt or adapt and update this guideline. It is not Quran Kareem. It is not a Holy Quran, or you see, this is the basic for the guideline, and we should adapt according to our circumstances, our resources, and the type of our patient.
Actually, they are telling to use the 3D for the uterine factor. Same thing they can use here also, no, to confirm the ovulation.
No, but you see, there is now a strong recommendation for use of 3D. It is mentioned in the ISHRI. It is mandatory in unexplained infertility, 3D ultrasonography. And recurrent pregnancy loss, it is mandatory. And recurrent implantation failure, it is mandatory, right? But it is, for the best of my knowledge, it is not mandatory or routine for assessment of the normal case of infertility.
Sir, your video is off. Cannot see you.
Sorry?
Abubakar, sir. We
Yes.
cannot see you. Your video is off.
Why?
Next is hydrosalpinx. They have mentioned either salpingectomy or occlusion. Suppose if you do the occlusion, the reasons for failure of fertilization here, it can that inflammatory cytokines that is released from this tubes with hydrosalpinx that can also interfere with the implantation.
Yes.
So that what I am doing, apart from the occlusion, we are doing the linear salpingostomy so that the fluid won't stay there. So that we have to do. Like if you do the occlusion, that fluid is going to be there, then cytokines will be released that can affect the implantation. That's one thing.
Linear salpingostomy, I think it will recur again.
Okay. Next is septum. They told, no, unless recurrent pregnancy loss is there, no need for us to do the septoplasty. That's what they have given. Will you accept with that? What is your opinion on that?
I am depending on the ASRAM. There is a guideline of the ASRAM. We can do septoplasty in primary infertility. And they put some prerequisites. It should be a multidisciplinary decision, and we should have a consent from the patient. This is the ASRAM guideline regarding the treatment of septum when the patient is suffering from primary infertility. And for me, if I am going to do ICSI and there's a septum, I will do septoplasty for sure.
Thank you for your explanation. Other people can ask the questions.
Sir, the camera part.
I have a question that you have mentioned not to go for serum prolactin. But I definitely go for it because many of our patients nowadays, they take domperidone, levodopa, they cause hyperprolactinemia. And that is not good for a good ovum production. So routinely I go and take the history also.
According to the guideline, all the guidelines, it is not routine. But I want to tell you one thing, my dear sister. The mild elevation of the prolactin is not detrimental.
Okay.
Right? You agree with me? And there's studies about the if you have less than 50, according to one study, it is beneficial. You see, against of all of our
beneficial to what level?
Yes. So a significant elevation of the prolactin when there is doubling of the normal level, but just elevated to be just 30, 35 of no value.
20,
Even one study found that this mild elevation, the outcome was better than the normal.
Yeah. But with that drug, I have seen the level is like 50, 60. That is detrimental.
Yes, yes, I quite agree with you. And also the very low level of prolactin is detrimental.
Yeah.
Yes,
audience,
my dear.
do you have any questions? You can put in the
yes. Any
box.
Questions?
Dr. Seema or Anuradha, any questions?
Yeah, very nice talk. Very basic. Everyone said it also. Dr. Reddy also said it. We all enjoyed it very much. And thank you so much for the enlightenment for both the talks.
I hope to meet again, inshallah, in another events. My regards to all the Indian doctors, all my friends in India.
Thank you, Abubakar sir, for taking time in coming because it is evening, still your hospital time, and then you could adjust and come and enlighten us for this recent guidelines, because that is regarded as one of the WHO thing which all of the practicing, even if you are not IVF, you must know it. Thanks for coming, sir.
I think also there is a very important and new is the Canadian guidelines for management of the niche, the cesarean scar defect. If there is the coming event, I can present this. The recent guidelines of the Canadian Society for Management of Cesarean Scar Niche. All are new and a very valuable recommendation for this.
So, sir, since you brought about that point, I like to need your opinion and other chairpersons, because niche there were, to some extent they were telling we can remove from down, we can make it shave, but for infertile patient, I think we have to correct it from laparoscopy. What is your take on it, sir?
Yes, sure. And this the most important is the residual myometrial thickness. It is less than 3 millimeter. Laparoscopy is highly indicated.
हेलो कैसे हो
Yes.
अच्छा है
So wonderful talk.
Thank
But I just
you, my
wanted to
dear
ask
friend.
one thing.
Thank you.
And you, Dr.
So that regarding this uterine niche, I just wanted to ask, should we close uterus in 2 layers or single layer to avoid this niche formation?
Yes, a very important question about the prevention of cesarean scar defect, and it is recommended a double layer and not to include the endometrium. And many other methods for prevention. The site of the incision, it should not be low as we were educated from other professors. It should be low. No, it should be above the utero-vesical junction, and also the to decrease the cesarean section rate, and especially the elective cesarean section rate.
Yeah, correct, sir. Very true. But these days we are finding many cases.
Yes, yes. So, inshallah, if there is the coming events, I can present this new guidelines of the Canadian Society.
Because if it is low, below the uterine vesical fold, then it is an improper approximation. You are very
Yes.
close to the internal loss, and then
Yes.
there is more chances of neck formation.
Yes, you are right. And it was found that this, when we are doing it low, the niche will be wide, will be large, big. You see?
So what I prefer is, it is just at the utrovesical fold, neither
Yes.
up nor below. You just push
Yes,
the
you are right.
bladder down and give the incision there.
Yes. So if there is no questions or comments, I would like to thank all of you and see you, inshallah. Bye-bye.
Thank you. Thank you.
Over to Dr.
Thank you, sir.
Anu, we'll conclude, no?
Bye. Yeah?
We'll conclude, no?
Yeah.
Yes.
Yes. So thank you. I think this is our last webinar, or one more we'll have.
So, ma'am, no, as per the discussion with Dr. Amit Patri, he said that no, this will be the last, but definitely in future we are going to collaborate, and we'll have that engaging evenings together.
So it was a wonderful journey. So we started in August 24 till now. We have completed 17 successful episodes of ISAR Catalyst series, and it was great working with Dr. Fessy our ISAR president, Dr. Amit Patki, Dr. Asha Bakshi ma'am, and all the seniors, and of course, UNS team. And it was so good. It was a wonderful journey. And I must thank Anuradha ma'am also, ma'am. Your comments are really valuable.
I must congratulate Anu and Dr. Fazil Lewis for this so many good catalyst input along with UNS, and I think you both are keep it up in future because it is very informative to all the delegates who are listening, and it's very good impact on the patient outcome. Thank you so much to all.
Thank you, ma'am. Thank you, Sanjeeva sir.
Thank you.
For
Ma'am,
accepting our
if you
invitation.
permit, shall I proceed for this thank you note?
Yes, Nakul.
Yeah, thank you, Dr. Fesi and Dr. Anu. So, thank you all the expert for joining tonight for this 17th edition of ISAR UNS Fertility Catalyst webinar. Definitely, means thanks to all chairpersons, all the faculty members. Your presence truly made this evening special. The session, which is offered, valuable insights. The talk is around updates in fertility management. We were delightful to witness the participations is more than 500 delegates. What I can see in the so I would like to thanks to my all distinguished speakers, Dr. Nandita, Professor Abu, along with all the chairpersons, as well as guest of honor, and this the for the enriching this contribution. So special thanks to Dr. Amit Patki, Dr. Asha Bakshi, Dr. Anu Agrawal, and Dr. Fesi for your constant support and guidance for this Fertility Catalyst webinar. So we look forward to many more such engagements and engaging evenings together now. Yeah, thank you, Dr. Fesi, Dr. Anu, Dr. Anujla. Thank you very much.
Thank you all. Thank you. Thank you, my teachers.
Wish
And
you good night.
Okay, thank you.